the top of the hour, so we'll get started here. I want to thank you all for joining the Superior Health Quality Alliance Roundtable conversation, which will focus on COVID-19 vaccine and the immune response. My name is Jerry Henniker, and I'm joined today by my colleagues Kelsey Ostergen and Kim Heft. And for those of you who have been joining these meetings before, we want to thank you for your keeping on coming back. And for those of you who are new to our call, we're glad that you've joined us today. We host these sessions each week. They consist of a 30-minute education session where we highlight important topics that are related to COVID-19 vaccinations and the boosters. And then we follow that with a 30-minute session where we discuss the topic of today or other topics related to COVID-19 or that may be of interest to you, and also some Q&A. We hope that you will be continuing to join us each week. One thing that we ask of you is that if you have any concerns or any pebbles in your shoe or things that you'd like us to discuss more, please let us know. We want to help you with those things that you're struggling with, those things that you're trying to figure out. If there's a topic you're interested in and would like to learn more about, just send me a message in chat through Zoom, or you can email any of us on the team with any suggestions or questions that you have. We'll be using the chat box today where you can share any of your comments or questions or anything else that pops into your mind during the presentation. We ask that you hold your question, and we'll be having time at the end of our session today for questions. So that way won't be opening it up for questions during the session, but more at the end. And also toward the end of the session today, we'll be putting a link in chat that allows you to provide feedback, not only on today's session, but the sessions as a whole. We want to know if these sessions are working for you, if they're covering topics that you're interested in, or if there's other information you'd like to receive. So please take a few minutes to answer those questions and provide us with feedback. Again, we want to know if this is working or what things we can do to improve. And then also, Kelsey has already popped in the chat a link to the PDF of our slides for today. As you're probably noticing, last week we had mentioned we were going to do motivational interviewing this week, but we had a little bit of a scheduling conflict. So today we are going to be talking about how to take a blood pressure. And you're maybe wondering, okay, you just said we're talking about COVID-19 and the vaccinations. And I think as many of you know, for COVID-19, those patients or residents who had chronic conditions such as hypertension, they were susceptible to more severe disease with COVID-19 and also to higher mortality rates, which is why we're talking today about how to take a blood pressure. In order to manage hypertension, you need to know if the blood pressure you're taking is accurate. So that's what Andrea Boscher is going to cover today in her session. With that, I'm going to turn it over to Andrea.
Great. Thank you, Jerry. And I'm so happy to be here with all of you today. And you might be thinking, like, why are we focusing on something that sounds so simple, like taking a blood pressure? It is a skill that does need to be reassessed every year for your clinical teams that are taking residents' blood pressure. So we're hoping that the information that's shared today is something that you can take back to your clinical teams, use it as a train the trainer, or maybe you can incorporate some of the information shared today as part of your annual competency training. So I'm hoping you get, some golden nuggets out of today. So our objectives for today is to look at the techniques for accurate blood pressure measurement and really strengthen those measuring techniques. We'll go over the 10 steps for proper blood pressure measurement. We'll also review blood pressure thresholds, and then at the end, I'll share some hypertension management strategies and resources. But before we jump into the content for today, I wanted to take a pulse of how those of you that are joining us today, how confident you are in measuring blood pressure properly. So if you're comfortable, go ahead and put it in the chat, but I'm just curious, on a scale of 1 to 5, how confident are you? 1 being you're not confident at all, 3, you can measure accurately most of the time, and maybe a 5 is you can always measure accurately every time for measuring a resident's blood pressure. You can feel free to privately message me, or you can just put it in chat. So I see a couple of you are at a 4 or a 5, so that's great. Hopefully, like I said, there's still some golden nuggets in there that you can take, because I know in my own experience, I know my blood pressure doesn't get taken correctly 100% of the time. So hopefully there's some good information here that we can share with you today. And I also want to make this session interactive for you. So hopefully you have something, a pen and a paper you can write something down with, or use your computer and jot these numbers down. But as part of this presentation, we're going to be playing a scavenger hunt game. So periodically throughout this session today, I'll ask you to notice some things about yourself and about your environment, and I'll tell you how to score those appropriately. So keep tabs of your points as we move through the presentation. And at the end, we'll tally those up. And just like golf, the lower the score, the better. So to kick it off, we'll do our first scavenger hunt item. And we'd like to know, are your feet on the ground and are your ankles uncrossed? So if you are like me, you are crossing your legs right now. So if your feet are not on the ground, or if your ankles are crossed, go ahead and give yourself 10 points for item number 1. All right, so I'm going to first start out with some level setting and starting out with a background. Before we dive into the measurement technique, we want to take a moment to talk about why proper blood pressure measurement is important. So we'll take a look at some facts. 1 in 3 Americans has high blood pressure or hypertension. And it's more common among some population groups. That includes African Americans and adults that are over the age of 60. So high blood pressure is also known as the silent killer because most people who do have high blood pressure are not showing any symptoms. There's also a connection to chronic conditions. So more than 65% of adults who have diabetes also have high blood pressure. And also more than 20% of adults who are 20 years and older and have CKD, and also 74% of people with chronic heart failure have high blood pressure. So those residents or patients who have diabetes are at a higher risk for developing hypertension if they do not already have a diagnosis. So it's time for scavenger hunt item number 2. Are your legs uncrossed? If you have crossed legs, go ahead and give yourself 6.5 points for item number 2. All right, so touching on the importance of accurate blood pressure measurements, we can't diagnose or even treat high blood pressure correctly if we're not capturing that blood pressure correctly through measurement. So making sure that we're taking residents' blood pressure correctly on every resident every time is really essential. So these accurate measurements are what leads to that correct diagnosis. Those blood pressure readings are what used to initiate treatment or monitor the effects of drug therapy if a resident is already on a medication for high blood pressure, also leading to timely and effective treatment, routine monitoring, and medication adherence. So as you're measuring blood pressure, if you are missing an elevated reading or you're underestimating the misclassified reading can be interpreted as a false normal level. That could lead to undertreatment, which could lead to further organ damage for that resident. If you're overestimating or you're getting a false high reading, that could lead to overtreatment. Also could lead to the possibility of drug-induced side effects. So that's why it's really important to use proper techniques so that your readings are consistent and reliable. So there's quite a few things that impact residents' or patients' blood pressure, and we divided these into 2 different factors. The patient factors, which are not always in our control, and the measurement factors, which are in our control. So those patient factors could be white coat hypertension. If they are having elevated readings in different healthcare settings, that could be contributed from the next bullet, that nervousness, that stress or anger. If they are sick at the time of their blood pressure reading, all of those things could impact their blood pressure. Specific demographics, age, sex, race, and ethnicity can impact blood pressure. Also lifestyle, poor diet, exercise, if they use substances, if they are smoking or use alcohol. If they are also taking a over-the-counter medication or a decongestant, recently consumed caffeine, or like I said, if they are a smoker, could also impact their blood pressure. And then also talking during a measurement could increase a patient's blood pressure. So those factors that we can control, and this is really going to be what I want to focus on for our session today. Patient positioning is really, really key to getting an accurate measurement. If there's air in the blood pressure cuff before measuring, that could cause an increased blood pressure reading. I touched a little bit on underestimating or overestimating blood pressure, that has a lot to do with the cuff size that's chosen. So if it's too large, that's going to underestimate a patient's blood pressure. And if it's too small, it could overestimate it. You want to make sure a cuff is wrapped evenly around a patient's arm, and that if you're using a manual device, you're not deflating the cuff too quickly. Again, with a manual device, not inflating the cuff high enough or inflating it too high. And then the auscultatory gap. So this is during a manual reading, it's when the pulse disappears and then it reappears while you're deflating the cuff. So if you're misinterpreting that gap, it could lead to monitoring errors. It could lead you to an underestimation of the systolic blood pressure or an overestimation of diastolic. And then looking at the gauge at an angle can also cause some measurement errors. So this slide highlights the blood pressure level thresholds based on the 2017 American Heart Association and American Medical Association guidelines. So what's classified as normal is a systolic of less than 120 and a diastolic of less than 80. Elevated is considered systolic between 120 to 129 and a diastolic of less than 80. And then where we get into those stages of hypertension, stage 1 is a systolic of 130 to 139 and a diastolic between 80 to 89. Stage 2 is then at a systolic of 140 or higher, or a diastolic of 90 or higher. And then when there's a hypertensive crisis, it's anything with a systolic of higher than 180 or a diastolic of higher than 120. So I have a pop quiz question for you here. And you can feel free to add your answers in chat. Does an elevated systolic or diastolic value put individuals at a greater risk for complication? I'll just wait just a moment for answers to trickle in here. Okay, you see, one of you said diastolic, and that is correct. So a high diastolic blood pressure does indicate greater risk for complications, especially those that are over the age of 55. All right, time for scavenger hunt. Item number 3 is your back supported. So if you are seated, but your back is not supported, you can go ahead and give yourself 5 points for this item. All right, so we've talked about the importance of accurate blood pressure measurements. Now we're going to walk through what equipment you're going to need for that. So at your facility, you could have different types of blood pressure equipment. So we'll cover each of those and how you can use each of those types of equipment to get that accurate blood pressure reading. So like I said, there's quite a few options for the equipment that could be used. In general, what the gold standard for measurement is going to be devices that have an upper arm cuff, as opposed to like a wrist cuff, or even the finger cuffs are not necessarily the gold standard. So on this slide, we've summarized the manual, the semi-automated, and automated devices. The top 2 on this slide show the manual devices, one that's going to be a portable version, and then one that is mounted to the wall, typically seen in like a patient exam room. So these devices, you'll be inflating the cuff yourself using the inflation pump, and you're going to use a stethoscope to listen for crawl cough sounds that are associated with the systolic and diastolic values. And then the automated and semi-automated devices, very easy to use, definitely reduces the chance for human error. With the semi-automatic devices, you're going to inflate a cuff manually by using the hand bulb, like your manual device. But once it's inflated, the device is going to start deflating automatically. And beyond that point, it will produce a reading itself. For the fully automatic blood pressure monitors, those devices have the electric pump for inflating, so it will do it itself after you push the start button. Very easy, does have minimum inputs from the user. So once the cuff is placed on the arm, it can be switched on, and then the reports are produced automatically. So if you're looking to reduce maybe the instance of white coat hypertension, you can set up a resident with an automated device, push the button and leave the room, and it can take multiple measurements that way. So it is important to make sure that devices are validated for clinical accuracy and that they're also calibrated periodically. So that means that the device is being tested to see if it's producing accurate readings. Typically what's recommended is the manual devices should be calibrated every 6 months. One quick way to see if a manual device is not calibrated is if the dial on the gauge is not resting at 0 when the cuff is fully deflated. For the automated and the semi-automated devices, those should be calibrated on an annual basis, and it's recommended to reference your device manual to see if you're able to calibrate themselves or have them calibrated by a manufacturer. So you talked about the different blood pressure devices. Next is the components that really make up the device. So what you'll need is your blood pressure cuff. So for the manual device, that is going to include the inflation system, which includes the cuff, the inflation bladder inside the cuff, the inflation pump, and the pressure control valve. And you'll need a calibrated sphygmomanometer gauge. If you have a defective one, that's going to lead to inaccuracy. So make sure that you are checking the accuracy of your devices. Definitely recommend to have multiple cuff sizes, ranging from even pediatric size to a thigh cuff, if you do have patients that would need to use that size. And then you'd also need a stethoscope if you're using a manual measurement. So for scavenger hunt, item number 4, are your arms supported at heart level? If one or both of your arms are not supported at heart level, go ahead and give yourself 10 points for item number 4. All right, so accurate readings are really the basis for identifying and also managing high blood pressure. So we'll walk through the recommended steps for measuring blood pressure to make sure that everyone on your care team is doing it the same way, making sure it's consistent technique and you're getting the most accurate readings possible. So our first step is to choose the right equipment. What you're going to need is that quality stethoscope if you're using a manual device. Whether you're using manual or automated, you're going to need an appropriately sized blood pressure cuff per that resident, and we'll cover how you know that that's a proper fit in a moment. And then also a blood pressure measurement device, whether that's the manual, semi-automated or automated. All right, step number 2 is to prepare the resident. So this piece is really important regardless of what type you're using. These guidelines are really the gold standard and should be completed when possible. It's definitely understandable that some residents would not be able to have their blood pressure measured in a seated position. If you do need to take the measure in a supine position, just make sure you are obviously making note of that. But before you're measuring the resident's blood pressure, you want to make sure you're allowing them 5 minutes of rest. That's, like I said, gold standard recommendation. Making sure that if the resident maybe had just, been seated, maybe they just had gone to the restroom, they're coming back to be seated, it's making sure that it's giving their blood pressure some time to return to normal. So going through each of these bubbles on the infographic on this slide, you want to make sure you're using the correct cuff size. Like I said, using a cuff that's too small could add 2 to 10 millimeters of mercury to a resident's reading. You want to make sure, if as much as possible, to put the cuff on their bare arm. If it's placed over clothing, that could add 5 to 50 millimeters of mercury. It can also make it really difficult to hear the pulse sounds if you're using the manual method. So if you do have a scenario where you have to roll up a resident's sleeve, you also want to make sure it's not being too restrictive. So we have a tip that you could place 2 fingers up in the sleeve of their clothing to make sure that it's not being too restrictive. And then supporting their arm at heart level. If it's unsupported, that could add 10 millimeters of mercury. So often these positioning factors are going to really depend on the availability of the resources that you have in the room. So it's best if they are seated in a chair that has an armrest or maybe a tabletop next to it. You can also use your waist to support their arm. If you don't have anything like that available to you, just making sure that they're not supporting the weight of their own arm. Making sure that they are seated with their legs and ankles uncrossed, because crossed legs could add 2 to 8 millimeters of mercury. And then while the resident is seated for the measurement, make sure their back and feet are supported. If they are unsupported, that could add 6 millimeters of mercury. Another tip is to make sure that they have an empty bladder. If they have a full bladder, that could add 10 millimeters of mercury. And then also making sure there's no conversations going on in the room. So if your resident is either talking to you, or even if they're actively listening at the time, maybe they're watching TV at that moment, that could add 10 millimeters of mercury to their reading. So these patient positioning techniques should help get an accurate reading as much as possible. I did want to mention, like I said, if you do have to take a resident's blood pressure in the supine position, the Journal of Hypertension does find that the systolic blood pressure has been reported to be 3 to 10 millimeters of mercury higher in this position as opposed to a seated position. Diastolic blood pressure is approximately 1 to 5 millimeters of mercury higher in that position. So if you do have a resident in the supine position, if the arm is resting on the bed, it's going to be below the heart level. So as long as you're making sure that the cuffed arm should be supported by a pillow or whatever you have available so that it's not below heart level. So step number 3 is to choose the proper cuff size. So I had mentioned a few slides back that a cuff that's too large is underestimating blood pressure and too small overestimating. So to make sure that you have the correct size on your blood pressure cuff, you should be able to see that there's an index line that runs along the width of the cuff. So as you're wrapping the cuff around the resident's arm, you want to make sure that that line on the width of the cuff is falling along the range. So that's going to be on the top of the cuff. So as long as it's wrapping around and fitting within that range, you know it's going to be a proper fit. If the cuff falls on the inside of the range, it's going to be too big. And if it falls on the outside, it's going to be too small. So scavenger hunt item number 5, are you dressed in layers? If you are wearing layers that could not be removed from one or both of your arms, you can add 27.5 points for item number 5. Step number 4 is to place the blood pressure cuff on the patient's arm. So you want to palpate where the brachial artery is, which is at the crease of the arm. And then you're positioning the blood pressure cuff so that the artery marker is pointing down towards the brachial artery. So you can, once you've located that, you can wrap the blood pressure cuff snugly around the arm. And a couple of 2-finger rules that we have to recommend is you want to make sure that there's 2 finger widths above the crease of the arm, especially if you're using the manual method. It gives you the space to place the stethoscope on the resident's arm. And then 2 fingers should fit snugly at the top of the cuff. So that way, you know, it's not too tight on their arm or not too loose. Step number 5 is positioning the stethoscope. So this is if you're using the manual method on the same arm that you put the blood pressure cuff, palpate where that brachial pulse is again, and place the diaphragm of the stethoscope over that brachial artery location. Step number 6 is to determine maximum inflation level. So this is also called the auscultatory palpatory technique. And it's a technique for you to use to determine really how high you should be inflating the cuff if you're using the manual method. So this is basically just to say that not every resident needs to be inflated up to a blanket number and inflated all at the same. So if a resident typically has a lower systolic value, they don't need to be inflated that high. That could make them feel a little bit more comfortable. It's not being as restrictive. Also, on the flip side of that, if they have a high systolic value, maybe over 200, it could actually accurately capture that. So a couple of options for maximum inflation. The first one is to inflate the cuff as you listen to the brachial pulse. So here you've already gone through steps 1 through 5. You have the cuff on the patient's arm, the stethoscope is on their arm, and you're going to slowly inflate the cuff until you hear those pulse sounds disappear through the stethoscope. So you're going to note that where you heard the pulse sounds disappear, and then inflate 20 to 30 millimeters of mercury above that level. So, and then you can deflate and take your reading. Option 2, on the other hand, you won't be using your stethoscope yet. You will have the cuff on the patient's arm. You can inflate the cuff as you palpate the radial pulse. So here you're feeling for the pulse to disappear. You would note where you saw that on the gauge and then inflate 20 to 30 millimeters above that as you're measuring the patient's blood pressure. All right, scavenger hunt item number 6 is, are you talking? So if you're having a conversation, go ahead and give yourself 6 points for item number 6. And step number 7 is to slowly deflate the cuff. So if you're using automated or semi-automated, this is going to be done for you after you press the start button. With the manual technique, you're going to need to begin deflation by gently loosening that thumb valve, and you want the pressure to fall at about 2 to 3 millimeters of mercury per second. That sounds extremely slow, but it's really helpful for you to make sure you're noticing where those cuff sounds are at the right level. Step number 8 is to listen for the systolic reading. So that's that first occurrence of pulse sounds that you hear as blood begins to flow through the artery, and that's the systolic blood pressure, or the top number. And step number 9 is listening for the diastolic reading. So you're going to continue listening for those pulse sounds as the blood pressure cuff drops, and the diastolic reading is the last pulse sounds that are heard before all sounds disappear, and it's the bottom number. Step number 10 is to double check for accuracy. So if the blood pressure is over 120/80, it's recommended to take a confirmatory measurement to determine if their blood pressure is elevated. So you want to note the individual readings. You can take an average of those to give you a snapshot for that day. Some of the automated devices will actually do that for you, but you can do an average of the readings to get an accurate picture of what their blood pressure is for that day. And scavenger hunt item number 7. So pardon the inquiry, but do you need to use the restroom? If you have a full bladder, you can go ahead and give yourself 10 points for item number 7. So what I'll be walking through next are just some best practices and some tips on blood pressure measurement as a facility. So a best practice for treating and managing hypertension is to implement a blood pressure protocol. So this makes sure that all clinicians are really diagnosing, treating hypertension in a standardized way. Of course, with exceptions based on their clinical judgment, and that these recommendations are really current and up to date. So this tool that's highlighted on this slide is from the American Heart Association and the American Medical Association, something that your team could refer to for a treatment protocol. So with this one, it is linked at the bottom of this slide, but you're able to click through each hypertension threshold, and it'll guide you through the recommended action, when to reassess, what next steps are, if the goal is met or not met. And bonus item for our scavenger hunt game, number 1. So have you had caffeine in the last half hour? If you have consumed a caffeine product in the last 30 minutes, go ahead and give yourself 5 points for bonus item number 1. Another recommendation or best practice is to do competency checks on your staff. So having a checklist, you can observe your staff's technique as they're measuring blood pressure. You can do this either in what I would say a classroom setting and do observations that way, or you can observe them on actual residents on how they're taking blood pressures. But in your checklist, you want to make sure you're including the steps that we walked through today on how to properly take a blood pressure, and make sure that your clinical staff is checked off as performed or not performed. It's also helpful to identify the steps that apply based on what blood pressure measurement device you're using. So if you're using a manual method, obviously there's going to be quite a few more steps as opposed to an automated. This is an example of a competency checklist. So it's a technique quick check by Target BP. Really breaks down all of the components needed in a proper blood pressure measurement. So you can walk through your clinical team's technique using a resource like this. And we'll go into bonus item number 2. So have you smoked in the last half hour? If you have smoked a tobacco product, go ahead and give yourself 5 points for bonus item number 2. And bonus item number 3. So were you just doing a moderate or high level physical activity? So if you're doing jumping jacks during this session today or something like that, go ahead and give yourself 5 points for bonus item number 3. All right, so with that, it's going to be time to add up your score. So like I mentioned, hopefully you were able to write down your score as we walked through our session today. So go ahead and tally up these points for all of the 7 scavenger hunt items, and then also those 3 bonus items. If you are comfortable, go ahead and share your score in the chat and we can see where everyone ended up at. And you might be wondering, what do these numbers mean? So each of these scavenger hunt pieces coincided with how much a resident's blood pressure could have been elevated. So for example, if you did not have your feet supported on the ground, like I said, that could elevate your blood pressure by 5 to 10 millimeters of mercury. So coinciding with the average points that you got in your score. So I'm seeing your scores coming in. So a couple of you are 5, 10, 44. So, you know, think about how that could have impacted your blood pressure reading. If you were to have your blood pressure taken in the exact position that you were in, how different could that have made your blood pressure? So also with those bonus items, having consumed caffeine or smoked or done any physical activity obviously also impacts blood pressure. So like I said, if you were having your blood pressure measured at this exact moment and those items were not addressed, it could have maybe given you a falsely elevated blood pressure reading. So with that, I'm going to pause and see if there are any questions on the information that I shared today.
If you have any questions for Andrea, you can either put them in chat, or if you're comfortable, you can just take yourself off mute to ask the question.
Andrea, this is Kim. I have a question in regards to wrist devices. I've worked and also have been at different clinics where I've seen them use the wrist blood pressure type of cuff. What is the recommendation on that, on using those, and how accurate are they?
Yeah, so some wrist devices, I will say there is a resource called validatebp.org, and I can add this resource in the chat. There are wrist devices that have been found to be clinically accurate. We would say they're not necessarily the gold standard. It's still recommended to do the upper arm device when possible, but if you know, a patient or resident doesn't fit into an upper arm device, or if there's not one available, there are wrist devices that are clinically validated for accuracy that can be used too.
Thank you.
Okay, any other questions? Well, I will put a question out to the group and just ask, was there one golden nugget that you learned from the recommended proper blood pressure technique that you can take back to your facility, or that you will incorporate as you're taking blood pressure readings? See a question in chat from Wendy. How often should you replace your device for residents? So Wendy, can you clarify, is that measuring in between residents? Is this residents' own devices? Can you just clarify that for me?
Yes. Also, I meant for if they had their devices at home also, like how often should they replace them?
Yes, that's a great question. So we do recommend, if they are measuring, you know, with their own device, that device is compared to the devices that you are using in your facility or your organization, so that those are checked for clinical accuracy. Typically, if there's any sort of visual, you can see that the tubing on the device is kind of, you know, coming apart. Visually, you can kind of see if a device does need to be replaced. There's not really a recommended, like, by X number of years to replace it, but you want to make sure that they are being checked, at least the resident or the patient's device every year, that their devices at home are being checked for accuracy too. Okay, any other questions? Okay. I think we can go ahead and maybe open it up for some discussion. I have a couple of kind of talking points, and I'm curious to hear from you all. What team members are mostly responsible for taking the majority of blood pressures at your facility? You can feel free to add your answers in chat, or you can unmute it and share. See, LPNs are mostly taking the patients or residents' blood pressures. So for those of you, do you host any competency trainings or check your staff's competency in blood pressure measurement on a regular basis? What does that look like in your facility? Kim says she's had it for CNAs, but not nurses. So that's good to know. Definitely would recommend nurses, physicians as well to have their competency checked. It's can definitely fall into certain habits where we take blood pressures a certain way and kind of forget, all 100% of the right ways to take a blood pressure. See a comment from Tracy. Personally, always used a manual method. Most often see the nurses using a manual cuff. CNAs and TMAs always use the electronic versions. Okay, yeah, that's definitely good to know. We see that in the clinic side of things too, where medical assistants, or the first blood pressure reading is started with an electronic or automated device, and then a confirmatory if you need to do one done with a manual technique. Great. So the second question I have on this slide is really trying to get to that patient positioning piece. What barriers do you see in being able to get to that proper, accurate blood pressure measurement technique? In reality, what are you all seeing that might prevent you from getting to those accurate readings? See a comment from Kelly that CNAs do most of your readings. The biggest barrier is communication. Yeah, definitely can see that as that's something that can be an issue, especially if they are elevated and need to be rechecked. Looks like your CNAs are tested for competency annually, so that's great. Yeah, definitely a barrier on staff being in a rush. And not being able to do the blood pressure with all the proper steps, definitely a barrier.
We had a barrier of just not even having the right size cuff. You would have your large and smaller, what have you, but then we would have the small little woman that needed a pediatric cuff, and we didn't even have any. So I would emphasize even having the right cuffs might be a barrier for some of the homes.
Yeah, good point. Thanks, Kim. It sounds like that's definitely a barrier. Tracy mentioned understanding the importance of that inaccurate cuff size. So Tracy, maybe this is some information you can take back to your team and share why that could give them inaccurate readings. Great. All right. Well, any final responses to these discussion questions? Well, hearing none, I guess, Jerry, I can turn it back over to you.
It's sure. I was just going to say, I just wanted to check too from our team. I know you've already had the discussion questions out there, Andrea, but just I wanted to make sure if there's any other questions or anybody from the Superior Health team who had any comments about what they've maybe observed or what they've experienced too. Wanted to just open it up for that.
I guess I could just add to the participants today on the call in regards to your blood pressure protocol and your policy. Do you have one? And, when's the last time it was looked at? The comment about when does a CNA report an abnormal blood pressure? What is that? What is that number? Is it the same for everyone? When do they report? Does everyone that come in and they're on some form of a cardiac medication, is there a blood pressure protocol written with each medication? And if they're not on any, do they at least get weekly blood pressures? Now, I'm not saying that this has to be done this way, but these are the type of things that I would see, I would think you would want to have in your policy. So I guess it's not so much a question to them, it just trying to start a conversation of making sure that policy is in place.
I just had a question for the group, and I know this may sound a little duplicative of what we've already been discussing, but so the presentation today, I know when Andrea and I and Kim were talking about it prior to getting it prepared, we know, there's the gold standard, as Andrea talked about a lot today, but we know that's not really always possible in all settings, not even just in the nursing homes. And so just wondering, from the presentation today, how much of this are you going to feel that you can take back, or are there things that you're going to do differently in your facility after this, listening to this presentation today? And again, feel free to take yourself off mute, or if you'd rather just put it in chat, or you can just even chat it to myself or Andrea privately if you prefer to do it that way. I'm not seeing anything. I do just want to make
And
sure.
Jerry, this
go ahead.
is Kristen.
Hey, Kristen.
Sorry, I just wanted to add too. I think that, like you were saying, wondering and what might be taken back. And I know we don't always have CNAs taking the blood pressures, but that this could be, a semi-interactive in-service type activity too, where, you're scoring yourselves and taking each other's blood pressures, or, even playing a bingo game of, can you mark off finding someone who had a blood pressure with a systolic or diastolic number of a certain point value as well, to get that practice in, and knowing that your CNAs can help you on the floor and gathering those numbers, and that they're doing it consistently to help your nurses out as well.
Well, and as you said that, Kristen, I was just wondering, because I know Kelsey's put the link to this training or these slides in chat. I'm wondering how many of you found the scavenger hunt helpful? Because for myself, just taking the scavenger hunt, I think really is kind of an eye opener of what the different things, how that can affect a resident's blood pressure. So just wondering if that is something that people might, in the future use in their facilities. Did they find the scavenger hunt helpful? I'll have to admit, I don't take it anymore because I know the answers, so I always make sure I'm sitting correctly when Andrea starts. But thank you, Wendy. And yeah, I do think it's really, I just feel it's a real eye opener to what the differences are.
So for Richard's wound, they have.
And Tracy said the slide that shows measurements that can result in lower adjustments with the proper seating, et cetera, is something that could be shared with floor staff. I agree. I think, and we realize, as Andrea said, sometimes there are residents who are maybe going to be laying in bed or in different positions. It's the gold standard, but just kind of knowing that difference, I think, is helpful for staff to understand why there might be a big difference between a resident's blood pressure from day to day, just on the positioning when they take the blood pressures. So. Well, if you guys want to just keep putting your thoughts in chat, or if anything comes to you, certainly feel free to do that. I did just want to make sure that we talk a little bit about our session next week will be on vaccine myths. I also wanted to let you know we will be doing the motivational interviewing session. It's just been moved till November. We don't have the date locked down yet, but wanted to let you know it's not canceled, just as being rescheduled. So next week, as I said, we'll be talking more about vaccine myths. And Kelsey just popped in chat to the link to our questions. We want to get your feedback. We really value your input. So please, if you can just take a few minutes to answer that. Again, it gives us an opportunity to hear from you and what more you'd like to hear about on these calls. I'm going to just put one last call out for questions. I'm not seeing anything in chat, but wanted to make sure that people had that opportunity. Wanted to thank you, Andrea, for the great presentation. I think it's something that really is kind of important and helpful for people just to kind of go back through how to take a blood pressure. It's probably been a long time for some of us. I know myself, since we were first taught how to do blood pressure. So I think it's always good to just kind of refresh our memories. If there's not anything more, I'm going to say goodbye for the day, and we'll see you next week. Thank you, everyone.